Well, good morning. I really appreciate the opportunity in being here. I feel like I'm the warm-up act, which is great. We have the world-renowned Dr. Spees and Hannon coming up after me, so just like any great comedian or music performer, there's always a warm-up act, but I'm very honored and feel very privileged to be here. Always good to come down to this meeting. I think I was here 2 years ago. I always learn something when I'm here, so I just appreciate the opportunity to come share our experience with TAVR with you today. So as an overview of my talk, we're going to talk a little bit about aortic stenosis. We all know the pathophysiology of aortic stenosis. We won't spend much time on that. We're going to talk about how TAVR came through the literature and became prominent. There's a very recent article just a week ago in the New England Journal of Medicine, the Partner 2 trial that we'll talk about that goes into intermediate risk patients. I'll kind of introduce you to our program at Lexington Medical Center. I'm a cardiovascular surgeon there. That's just outside of Columbia, South Carolina, a little suburb there in the Midlands. Talk to you about our TAVR program, and then spend the most amount of time talking about this new access method, what we call Transcaval Access. So aortic stenosis, as we all know, the aortic valve leaflets are supposed to kind of be like sails on a ship. This is the way I explain it to patients. They're just supposed to move out of the way, make egress of blood out of the ventricle to the heart very easy. As people age, these become thick and leathery, calcified, especially in postmenopausal women. And then they don't move so much, and that causes a problem. That leads to a decreased effective orifice area, basically. And so it causes the heart to work harder. That's good if your bicep has to work harder when you go to the beach. It's not good for your left ventricle to have to push blood through that narrow opening. The muscle hypertrophies, it gets bigger. Bigger muscle needs more oxygen. It can't get more oxygen because more blood can't go through the aortic valve, and then symptoms develop. Those symptoms are usually shortness of breath, fatigue. I just can't go like I used to. This is a little hard to sort out sometimes in patients, obviously, because a lot of these patients are in their mid-80s and they're slowing down anyway. Certainly they can develop angina or chest pain, and this can be, again, described by the patient in different ways, sometimes hard to sort out. And then the last of those three symptoms is syncope or sudden death. And I didn't put the slide up here next, but if you have a valve area of less than 1 centimeter squared and you have symptoms, your mortality is 50% at 2 years. And that really pales in comparison to any of the, our cancer type outcomes. So it's a very mortal disease, aortic stenosis is. It's also becoming much more prevalent. There's probably about 1.5 million people in America that have aortic stenosis. That number goes up every day as our baby boomers every year are reaching the age of 65 and get into their 7th and 8th decades of life. So that number is going to continue to go up. There's probably about 500,000 people, about 500,000 people with severe aortic stenosis. There's probably 250,000 who have symptoms in severe aortic stenosis. And this is a very important number because this is the number of people who have a mortality of 50% in the next 2 years, which is very high. But yet, if you look back in all the databases, we were only doing about 85,000 aortic valve replacements a year. So there's a huge disparity between the people who needed the treatment and the people who were getting the treatment we had to offer. And there's a lot of reasons for that. Certainly, a lot of these patients are very elderly, and their primary care physicians, they never even send them to a cardiologist. Or maybe the cardiologist has known them for a very long time and just never sends them on for any other therapy because they knew they really weren't surgical candidates. And so this was why there was a big push to try to bridge this gap and obviously find a way to treat these patients because we weren't treating them surgically. And obviously surgically is historically the only way to cure aortic stenosis. Well, certainly the corporations saw this a long time ago. This is a slide, I think, from 2009, an article in 2009. And this was Edwards' estimation. These are all estimated figures on how many transcatheter aortic valves they thought they could do. And they thought by 2015 it would be in the 100,000 range. And they've been pretty good on their predictions. And as you can see, this is they look at it from an economic standpoint and a huge revenue stream, over $1 billion. So this is a picture of a TAVR. Obviously, this is a Edwards or a balloon mounted valve. I have no financial disclosures at all. We use both the Medtronic and the Edwards valves equally. I think both of them have their pluses and minuses and strengths and weaknesses, and finding the right one in your particular patient is what's most important. Again, delivering a valve on a catheter into the aortic position and deploying it, as you're all well aware of, is what we're talking about with transcatheter valve replacement. So this is the Partner 1 trial. This came out in 2011. Originally looked at two different groups. One was high risk, and this was people who had a risk greater than 8% by SDS calculation, and compared them with a transcatheter valve versus a traditional surgical valve. And then there was an inoperable arm, people that everybody just said we shouldn't touch these people, and they either had transcatheter valve replacement or medical therapy. So again, this is just a breakdown of the design. We're going to talk most about the high risk, but in the inoperable arm over here, people who did not have what we would consider standard therapy, which is medical therapy, which is really not effective at all at treating this disease process, their mortality at 2 years was actually 68%, higher than some of the historical methods. This group of patients did end up doing better, but had a pretty high mortality regardless of what we did to them. But we're going to talk specifically more about this high risk where they were randomized to either transfemoral route, and so they either had transfemoral TAVR or AVR, or transapical. They either had TAVR or standard AVR. So this is a look just kind of at their baseline characteristics. This is a very old group of patients, average age of 84. It is a little interesting that the transcatheter valves were actually average age of 83, average age of 84, and the surgical valves didn't come to significance, but it's unusual in a large randomized trial like that to see even that difference. But otherwise, they were pretty similar patients. Their predicted mortality was 12%, pretty consistent between both groups. A very high rate of reoperations. 44% of these people had previous cardiac operations. So again, a very high risk group of patients. There we go. So when those results came out, the risk, this was a non-inferiority type trial. The risk of mortality was essentially equal. Stroke significantly favored surgical valve, and perivalvular leak favored surgical valve. And you can see here, this is the risk of death from any cause at 30 days. And it, again, was equal between the two groups. 3% in the transcatheter valve, 3.4%, and about 6% the surgical valves. It's interesting with a predicted risk of 12% that the surgical risk actually was only 6%. So sometimes our prediction models are not as good as we'd like them to be. Again, stroke was kind of the Achilles heel of the transcatheter valve replacement, 5.5%. Pretty low stroke risk in a sick group of patients surgically. Again, 44% of who were redos. So again, as you look at these curves, they don't really differ. Again, a non-inferiority trial, and we concluded from this that in high-risk patients, it was reasonable to consider those patients for transcatheter valves. This is the latest study. This is an intermediate risk, and this is very common in medicine, and we'll talk about this a little bit, this indication creep. We start with a procedure on very high-risk patients and almost, in trials. And then it continues to get better. The technology gets better. We get better at providing. We choose patients better. And so the indication continues to creep down, and this is certainly happening in TAVR. This just came out about a week ago in the New England Journal of Medicine. And this looked at a group of patients who were considered risk, and to be enrolled in this, your risk had to be calculated at 4 to 8%. That's what intermediate risk was thought to be. Again, a little younger group of patients, average age of only 81. Again, their predicted risk as a whole was about 6%, significantly lower redo rate in this group of patients. Where's the best place to point it? There we go. Thank you. So again, in this study, no real difference in stroke or death. When you looked at this, death from any cause. No significant difference between the two at 30 days, or really as we get out here to 2 years. They follow these patients for 2 years. This study was actually started in 2011, back when the first trial had actually come out. Certainly TAVR has a better orifice area for the valve than do surgical valves, and I'll talk about that just a little bit. TAVR had less renal failure, AFib, and less bleeding. Really the only place where surgical valves really did better than the TAVR valves was on new perivalvular leak. And again, we'll talk a little more about that. That is certainly the Achilles heel for TAVR valves, and will be as they start to look to trying to do these valves in lower risk patients. So again, this is just some survival curves of intermediate risk, and you can see the red on the top is the surgery, the blue underneath is TAVR. This is just a blown up slide of this. This is intention to treat and as treated. They really don't differ very much. Transfemoral, you can see a little more separation between these two, and at 2 years the difference in this mortality almost reaches significance. It's about 4% difference there. We'll talk about that. So in this group of transfemoral patients, again, a lot of these TAVR patients still had transapical approaches, which certainly had higher complication rates. You can see this odds ratio very nearly comes away from 1 in this transfemoral group, where TAVR would be favored over a surgical valve in an intermediate risk patient. And I think that's pretty significant. So we'll talk about these 3 subsets. Again, I mentioned it earlier, aortic valve area. What is the valve area when you're finished doing either your TAVR or your surgical valve? Perivalvular leak, we'll go into a little further, and what perivalvular leak means to patients. So this is the effective orifice area or aortic valve area after replacement, and there's no doubt in my mind as a surgeon that these TAVR valves have better hemodynamics than do surgical valves, which you would just from their design think is true. A surgical valve has a sewing cuff, which takes up part of the ventricular outflow tract. There's also stent struts. The only really way to get away from that surgically is to do a root replacement, which most of these patients wouldn't tolerate or would be more difficult. These TAVR valves, all that's there is the frame and a very thin frame of metal, and then the valves are mounted to the inside of that. So their effective orifice areas are much better than surgical valves. And this is bared out in the trials, and it holds up over 2 years. And a lot of people ask, will these valves wear out? If we're going to put these in intermediate risk patients, if we're going to start putting them in low risk patients, 65-year-old people, are they going to last long enough, to be worthy of putting in those type patients? And I think there's really no difference in how these valves are going to last in surgical valves. Technically, they're the same type of materials used, same processes to treat them, and so I don't really think that we're going to see a difference in how long they last, their longevity. I think they'll probably last in that 12 to 15 year range that a surgical valve lasts, a tissue valve. This is perivalvular leak, and again, this is the Achilles heel of the TAVR valve. You can see that these are surgical valves here, very rare to have a perivalvular leak in those patients. The red on top is severe. You can see it really doesn't get better with time. It actually probably gets a little worse. In other words, if you leave it, it's not going to improve. It's going to get worse over time. That bears out in the mild. This is the lighter color orange there. It gets worse over time. It doesn't get better. The number of patients who have it. So you can see here at 2 years, you're talking about a pretty significant, about 35% of patients who have a perivalvular leak. And I think that's very important as we start to think about putting these in lower and lower risk patients. And the reason it's important is these are the survival curves for patients with perivalvular leak. And this curve right here is moderate or severe perivalvular leak. And these curves are for trace or mild or none. And you can see that trading aortic regurgitation for aortic stenosis doesn't benefit these patients at all. They have a significant mortality rate, much different than you would expect for just curing their aortic stenosis. So again, certainly the corporations are working on this very significantly. And again, I think this is where it's important to choose the right valve for your patients. A lot of patients have bulky calcific disease that kind of palisades down onto their anterior leaflet of their mitral valve, and there's better valves for that than the other valves. And so choosing your patient very effectively, trying to eliminate this perivalvular leak is a very important part of choosing which valve you use for these patients. So again, as we look at these studies right now, TAVR is approved for high-risk patients. That's a greater than 8% predicted mortality. It's approved for valve-in-valve, which is, I think, a pretty effective therapy. I think this approval will be coming soon after this last trial. It'll have to go through the FDA, obviously. Right now, there is a low-risk trial underway. And the question always comes, will surgical straightforward aortic valve ever go away? And my answer would be, as we know it, I think it will eventually. Will we replace 50-year-old's bicuspid valve with a TAVR? Probably not. We'll probably continue to do aortic valve replacements on those. But I think for the vast majority of patients, 5 years from now, 10 years from now, those patients aren't going to get a straightforward surgical AVR. They're going to get a transcatheter valve. In a very low-risk patient, somebody who doesn't have any comorbidities, that 60 or 65-year-old person, their risk is really 1% with surgical aortic valve and very low risk of stroke. And so that's kind of where TAVR has to go. It has to get that good before we can consider it in those patients. And so if you look at the mortality in TAVR valves, and this is at 30 days, from partner 1 to partner 2, even though the devices have gotten better, less stroke, less vascular bleeding because of smaller sheaths, the mortality really hasn't changed. In the partner 2 trial, it's actually slightly higher. So before we get TAVR into these low-risk patients, this is going to have to get better. This is going to have to get down to that 1 to 2% range before we can consider using those in the lower-risk patients. So I wanted to look at just some historical models from medicine. Will surgical valve go away? And you look at laparoscopic cholecystectomy, widespread use in the late 1990s. You can see the rate of laparoscopic cholecystectomy is basically doubled over this 20-something years that laparoscopic cholecystectomy has been used. The serious complication rate, if you do it open, is exceedingly low. The serious complication rate of bile duct injury is 10 times higher in laparoscopic cholecystectomy, but we accept that. We make a margin of error for a less invasive procedure is a little bit less. So as a society, as a patient, as a surgeon, we've accepted doing these because people get back to work earlier, they have less other wound complications, there's less pain involved. And so again, from that standpoint, perhaps slightly less procedure as it relates to complication we accept. We see this in breast cancer when you talk about lumpectomy versus mastectomy. A lumpectomy with radiation is the standard of care now. Nobody has a mastectomy anymore unless it's for preventative measures in general. It requires 5 to 7 weeks of post-op radiation, which is a huge healthcare cost. The number of surgeries is much higher because you have to go back and get margins if you do a lumpectomy. The local recurrence rate is much higher with lumpectomy versus mastectomy. Slightly less long-term survival, long-term, with lumpectomy versus mastectomy. But there's no longer a debate. People don't talk about this anymore. This went away at meetings 15, 20 years ago. Lumpectomy is the accepted standard of care with radiation for women with breast cancer. Again, medically it's probably a little bit less, but we accept that because it's less invasive. People are more functional after surgery, and so we make those trade-offs as a society, as a patient, as physicians. We certainly have seen it in our area with stents versus CABG. Many trials prove that CABG is better for left main, 3-vessel disease, diabetics, but yet we continue to see the rate of angioplasty go up and the rate of CABGs performed go down. Again, people are back to work sooner. They don't have to have their chest ripped open, so to speak. So again, we make these decisions, again, as a society, as a healthcare team, as a patient. Everybody is participating in this. It's not a blame thing. It's just how we operate as humans, I think. You want to advance it? Yeah. Oh, thank you. So historical models in life, not just medicine. Certainly these are, the first cordless phones some 30 years ago. Didn't fit in your pocket. Drug dealers probably had them, some VIPs. Now we have iPhones. You don't really ever have to get out of bed. You can ask my teenagers that. It's not just a phone. It's your computer, internet, game console, and everybody has them. So just in life in general, we advance very quickly. Technology advances very quickly, and we in medicine have to keep up with those advances and try to choose those therapies the best we can for our patients. So again, Edwards' prediction of how many TAVRs they think they're going to be doing. They may have underestimated this. I do think that 5 years from now that the majority of these patients, and up to 250,000 people with severe aortic stenosis, will be treated with TAVR valves versus having surgical valves. And that's a great thing for our patients. Those patients weren't being treated at all. They were just dying miserable deaths. And so to have a therapy to offer them to extend their life and hopefully not only give them quantity of life but also quality of life, I think is a major advance. So I want to transition a little bit here and talk to you a little bit about our program at Lexington Medical Center. Again, and this is in South Carolina. It's just outside of Columbia, South Carolina in the Midlands. The hospital was established in 1971, which is also when I was established, so to speak, when I was born. It's a community-based hospital without any training programs. Right now we're licensed for 428 beds. We're actually going to build a whole new tower and have licensing up to 650 beds, so we're expanding. In 2001, the hospital had fought for about 10 years to get a CON for open heart surgery, and they got that in 2011. And we did our first open heart procedure March 28, 2012, so we just celebrated our 4-year anniversary. This is a picture of our first case. One person you don't see in this picture should be standing over here, and that's the esteemed Ty Walker, who came and helped set up the program with me there at Lexington. I could not have done this without him. I couldn't tell you how gracious and how much gratitude I have to Ty to being a partner with me. He's made me a better surgeon through pushing me to try new things, team approach, blood management, which we're going to hear a lot about later. And those great statistics he quoted, even though they're probably a little bit low, could not be achieved without the hard work that Ty's put in. So our program, these are fiscal year numbers, so they end in September. But our first 6 months we did almost 100 cases, and we've grown pretty steadily through then. The first 6 months of this year we've done about 202 cases. I think we're going to get to 400 this year. This is all open heart. This doesn't include our TAVRs. Our TAVR program started May 30th, 2014. We have 2 cardiologists. We have 1 main cardiologist. He was trained at Emory in the structural heart program there, did an extra year, did most of those partner valves in that first trial, so very experienced. 2 surgeons. From day one, we started doing these transcatheter valves fully awake. The patient's just having some Versed or fentanyl. We do them totally percutaneous. We've cut down on, I think, 1 patient so far in all our procedures. And this is a great benefit to the patients, I can tell you that. Not having any general anesthesia for these old folks. A lot of them don't tolerate a bad haircut. And so not having to give them any general anesthesia, you have a lot less delirium. You can get them back on their feet the next day. They can leave the hospital after 2 days, and they just don't sit in the hospital and get all the problems that sometimes we create for those patients. So this is our team right here, and initially it started off as a very large team. It was very fun to kind of coordinate. You have a lot of cath lab staff here, OR staff, anesthesiologists. We have our perfusionist right here, and Frankie's in the audience with us today. But they're a big part of our TAVR team as well. And I know sometimes y'all don't feel like that you are as we start to do these more and more out of the operating room, etc. But they've been a big part of our team. It's been very fun getting this team up and going and working together. So this, in our first 4 months, again, these are fiscal years for us. September, we did about 18 cases. The next year, about 68 cases. And it looks like we're going to get to be about 80 cases this year. Again, having somebody that was so well trained, and Dr. Leonardi come and join us, we've been able to achieve a pretty high rate of transfemoral access. I'll talk a little bit about our transaortic access, which hasn't been the greatest, although we've stayed away from it. We've done a couple of transapical procedures. We've actually only done 1 TAVR through a transapical procedure. And we've done 2 mitral valves with valve and valves. And this is a pretty good procedure right here. Both those patients have done very well. They had tissue prosthetic mitral valves. They'd had multiple open heart surgeries before. And from a transapical exposure, it's very easy to put one of these valves within that valve in the mitral position, and they seat very well. They have something to grab onto, and those patients have done very well. I wish I had the video, but I couldn't get it to work. And then what I'm going to spend a fair amount of time talking about is this transcaval approach. So again, as we talk about fully percutaneous, not really having to take a scalpel and lay it to the patient, we've done that in about 90% of our patients. So our complications, again, this is where our perfusionists on standby have come by. We've had 2 aortic repairs just out of those 9 patients. The sheaths that you put the TAVR valve in are 24 sheaths. One of these patients was a 91-year-old lady who'd been on chronic steroids for life. I could see the red blood cells circulating through her aorta. And when we opened, I was like, this isn't going to go well, and it didn't go well. Both of those patients we put on bypass through the groin, repaired their aortas. They ended up doing okay. They weren't catastrophic events, except for me. But it let me know that this isn't always the best therapy for these patients. They still get surgical incision. It's really not that different from the surgical aortic valve, to be honest with you, from their standpoint and the way those patients did. Even the people that didn't have complications. We did have 1 pericardial effusion from removing a pacing wire or perforating the right ventricle with a pacing wire. We had a hard time getting in and exposed. It's kind of the end of the procedure. We ended up putting that patient on cardiopulmonary bypass. She ended up doing okay, able to drain that. And then we had 1 bypass that we did just simply for support. The patient had a very poor ventricular function. We didn't feel like they'd tolerate a pacing run, and so we went on just to support them. Put a couple of intra-aortic balloon pumps in, again, just for support after very long pacing runs. Those patients have done well. We've had 2 vascular injuries in those 127 patients, and both patients we were able to stent our way out, so to speak. These were iliac perforations, put covered stents in. Again, the procedure was maintained as a percutaneous event, and those patients also did well. So as we look at alternative access for TAVR, certainly aortic is one way. Again, a lot of these patients have had previous cardiac surgery. They have grafts on their aorta. It's not a great access for a lot of patients. Transapical, these patients don't do very well. It's a reasonable size thoracotomy incision. A lot of them have COPD anyway. They get a thoracotomy and hurt, and they don't do as well. It's very similar to having a sternotomy. Carotid is certainly an option in these patients, and that's certainly been described. Subclavian, sometimes not the greatest option due to the fact that the subclavian artery sometimes is stenotic. A lot of times these patients have previous bypass. They have an IMA coming off their subclavian artery. You really don't want to run a big sheath by that. And so people started looking at what are other ways, and obviously this is cardiologist driven because they're used to being in the groin. What is a way we can stay in the groin and still offer some of these patients access? And that's where the Transcaval came from. So this was developed at the NIH by Dr. Robert Letterman. He is mainly a researcher. He's not a clinician, and he's just trying to write grants and figure out ways to offer TAVR therapy, and he found out he could do this in pigs. And then he went to a cardiologist that he knew well in Detroit, and they started doing this in patients as well. Dr. Leonardi saw this at a presentation at a meeting and decided he'd try to bring it to LMC. So the first case of Transcaval Access was in 2014, done at Henry Ford. Been about 170 cases to date worldwide, almost all of those for TAVR. There have been 4 thoracic endografts put in this way, and we've done one of those. Oops. So again, we've done 6 TAVRs and 1 thoracic endograft, and all these patients have done well. We've had no transfusion, we've had no open conversions, and I'll talk to you about the 30-day CT scans that we get on them. So again, the background and rationale, these devices require large sheaths. A lot of people are women, they have small arteries or peripheral arterial disease. Vascular complications still remain significant. Sometimes these are contraindicated, the other access routes as we talked about, so we're looking for a way. Femoral veins are large and more compliant. It was noted that aortic cava fistulas aren't as bad as some people think. In some ruptured AAAs, they're not immediately life-threatening, and so that would be one of the complications of trying to drive a big sheath here and make a connection. These 2 vessels are usually very close together, and again, they started out in pigs and had pretty good success. So let me present you a patient that we think this would be a good access method on. This is a 73-year-old gentleman. He's previously had a CABG. He has 2 patent mammary grafts. His right mammary is sewn to his LAD. His left mammary is sewn to his ramus intermediate. He's had bilateral carotid endarterectomies. He has PAD with lower extremity claudication, very severe COPD. Again, very high predicted STS score, but all our access points that we normally use really aren't available. This is a picture of his coronary angiogram. Again, a pedicled lima to his ramus and a pedicled rima to his LAD, and it crosses the midline. So again, open surgery is going to be very difficult. Aortic access would probably be impossible. Subclavians aren't a good idea. His legs, femoral arteries are not adequate, and he's had bilateral carotid endarterectomies. Probably has eliminated most of our normal or alternative access sites. This is just a picture of his lower extremity angiogram. 5 is kind of our cutoff, and that's without calcification to put the size sheath in that he needs. As you can see here, it's circumferential calcification, and this is in multiple areas, and this is really the bugaboo. When you put a sheath up there, if there's a couple different places where there's circumferential calcification, then that's where you get the tears, because it really locks onto that sheath, and as you pull the sheath out, it finds the weak spot where there isn't calcium, and then they tear, and this is when you have your catastrophic events. We'll skip that. That's just the definitions that when we apply for the ID protocols, favorable, feasible, and unfavorable, based on where the aorta and the cava lie together. So again, we go in very extensive planning for these. CT scan is very important to identify a location where the cava is very near the aorta. There's not, sometimes the duodenum comes right here, or bowel comes across there, and that's very important when we line things up. All these patients have a significant amount of calcium, so we have to find a window in here where there's not calcium, because the method we use to cross will not go through calcified plaque. So again, very fancy CT scans, spin these around, find the best spot, locate exactly where they are in relation to the vertebral bodies, because that's what we're going to be looking at in the operating room on fluoro as our crossing point. And so this is the technique. You take an IM catheter guide and put it here in the vena cava after shooting a vena cavagram and an aortogram. And I'll show you. This right here is a 014 guide wire, and you cut the end of it off to make it sharp. You have what's called a converter that takes it up a little bit larger. This is a Navicross. It's 035. And you can put an 038 wire through this, which is what the big stiff wires are. And so when we put this up here, we hook it to a bovie, and we turn it on 50 of cut and 0 of coag, and turn it on, and it will cut right through this just like a hot butter knife, hot knife through butter, with no real difficulty at all. So again, when we do that, a wire is also placed in the aorta here, a snare, and we put that through the snare, grab it, and drag it up into the aorta, and then we progressively dilate over that wire from the vena cava to the aorta, and then we get our big sheath in. So again, just kind of some step-by-step process. This is that IM guide at 7 French, and we put it right where we think it should go. You can see some of the calcium subtracted out of this, but shoot an aortogram and a venogram at the same time to locate our crossing point. This doesn't project great, and I apologize for that. And so this is a snare that's in the aorta. That's our crossing guide right there. And this process takes a little while. We go back and forth between AP and then lateral. We want to make sure that that catheter is aimed directly at that snare. And again, this is where the anterior-posterior is important, because there is bowel right here. And then this is the process where we turn that bovie on, and that wire comes across through that snare. And if you don't turn the bovie off quick enough, that wire will go right out the other side of the aorta. It moves through there very quick. It takes a coordinated effort on the person on the bovie and the person pushing. But then that's snared, and again, that snare is driven up the aorta. Again, this is kind of a 3-level jacket. So the first is the skinny wire that crossed. The next is a confianza wire that goes up over that. Then we take the navicross up and across, and then we pull the 2 out of the navicross, and then we have a Lunderquist wire up in the aorta with very good purchase and a stable crossing point. So again, this is just building that jacket of 3 wires and the converters. We have to connect the bovie to that first wire there. That's the small confianza wire. Cut the end of it off to make it sharp. And so again, we end up with a very stable sheath from the vena cava into the aorta, and then we just proceed with TAVR normally. At that point, we don't have any hemodynamic problems. There's a large sheath plugging this connection between, so there's not really any bleeding. We haven't experienced any of that. These patients are very stable, and then we just go about our TAVR, and it doesn't matter which type of TAVR we're using. We've done this with both of the valves just as normal. And then, well, we have to close it. So to close this, we just take usually a PDA closure device, which is a large wire mesh disc on one side, and it looks like a mushroom, and it comes back across that hole. And we just slowly unfurl that and plug this hole, and it works very nicely. And we end up with a couple different pictures when we're done with this. There we go. So again, this is the closure device you can see right here being let go in that hole. And so the large wire mesh portion of this is within the aorta. It's much larger than the hole that we made. In this patient, we did end up with what we would call a type 1 aortic caval fistula. This is also wire mesh, and it closes over time. And again, we've gotten CT scans at 30 days on all these patients, and they're all closed. We monitor their CVP very closely to make sure they wouldn't get congestive heart failure. And there's just not much flow through this. This is like putting a coil in any aneurysm in the body. Metal within the bloodstream is going to clot eventually. So, again, this has been very stable for us and closed over time. And I think that's what the worldwide experience has been as well. So, again, 7 cases. We've had no real bleeding problems, no transfusions, no further interventions. The bailout for this is to put an endograft in the aorta. We just take an iliac limb, which is small enough to go through their peripheral vascular disease. You can take most of those up bareback and only require about 4 millimeters of artery space. And then you would just deploy that if you had bleeding complications, if you had some problem with the aorta. I think in the worldwide trial right now of the 170 patients, that's only had to been done once. So, again, it's been fairly reproducible at several different centers. Again, at 30 days, all our aortic caval fistulas have closed. None of them have been open. So in conclusion, I think TAVR is here to stay, and I think it's going to continue to advance that indication creep that we talked about. It's going to get better and better. The sheaths are going to get smaller and smaller. Again, in medicine, indication creep is the law. I think alternative access will always have a role in these patients because they've had previous procedures, because they have other disease processes. And I think being able to do this from a transcaval approach certainly widens the spectrum of people we can apply this therapy to. And I would just say to a group of perfusionists who sometimes feel like they get pushed out of this arena is just like me as a surgeon. I have to just keep sticking my nose in there with the cardiologist. This is kind of their realm, their playing field. But, I push myself every day to try to keep up with them, to try to advance my wire skills to be a part of this, because there's a lot of things like the endograft to do these. They've never done endografts, or at least our cardiologists hadn't. I know some do. But, there's always things that we can add. There's always expertise that I have that I can add to the cardiologist. There's expertise he has that he adds to us. There's expertise that perfusionists have that can add to this team. And so, again, Ty talked about that a little bit when he introduced me, but I'm a big believer in teams. We all have something that we can add. We don't know what we don't know, and there are people around us that have tremendous training and experience and can add something. If that can benefit your patient, we should be as inclusive as we can in allowing everybody to participate in caring for these patients. Because even if it's 1 or 2 patients, this transcaval access isn't going to be a large percentage, but it extends our ability to treat these patients who would die otherwise and replace their aortic valve and let them go on and live, again, not just a good quantity of life, but really improve their quality of life. So, again, I appreciate the opportunity to come and talk to you, and I'd entertain any questions.